Good morning, interns. Welcome to the first part of your virtual internship. This is a brief introduction to urinalysis. Urinalysis, as defined by the CLSI, is the testing of urine with procedures commonly performed in an expeditious, reliable, accurate, safe, and cost-effective manner. The reason why we perform this in the lab is because this is important in aiding in the diagnosis of disease, screening a symptomatic population for undetected disorders, and monitoring the progress of disease and the effectiveness of therapy. As we all know, urine is an ultrafiltrate of plasma, and the reabsorption of filtered substances converts approximately into 1,700 ml of filtered plasma. This in turn gives an average daily urine output of 1,200 ml. A range of 600 to 2,000 ml is also considered normal. In general, urine consists of urea and other organic and inorganic chemicals dissolved in water. Urea, being the primary organic component, accounts for nearly half of the total dissolved solids in urine, with creatinine and uric acid. The major inorganic component is chloride, followed by sodium and potassium. So to determine that a particular fluid is urine, specimens should be tested for urea and creatinine content. Urine has a much higher concentration of both substances than other body fluids, so to identify a fluid as urine, it is best to test it for urea and creatinine content. For urine volume, we all know that the body's major constituent is water, and the amount excreted is usually determined by the body's state of hydration. The factors that influence urine volume are fluid intake, fluid loss from non-renal sources, secretion of the antidiuretic hormone, and the need to excrete increased amounts of dissolved solids. Oliguria is defined as decreased urine output, and this is commonly seen when the body enters a state of hydration as a result of excessive water loss from vomiting, diarrhea, perspiration, or severe burns. And in infants, this is usually presented as less than 1 ml per kg per hour. In children, which is less than 0.5 ml per kg per hour, and in adults, which is less than 400 ml per day. Anuria is defined as the cessation of urine flow, and oliguria can lead to this. On the other hand, nocturia is increased urine output during the night. Normally, urine output is 2 to 3 times during the day than at night, but in nocturia, urine is increased at night than during the day. For polyuria, this is increased urine output, and it is usually associated with diabetes mellitus or diabetes insipidus, but it can be induced by diuretics and coffee or alcohol by suppressing the antidiuretic hormone. In adults, this is manifested as greater than 2.5 liters per day, and in children, this is 2.5 to 3 ml per kg per day. For specimen collection, specimens must be collected in a clean, dry, leak-proof container, and disposable containers usually eliminate the chance of contamination due to improper washing. The recommended capacity of the container is 50 ml, and this allows for 12 ml of the specimen for microscopy and an allowance for repeat analysis, and it also gives enough room for the specimen to be mixed. Labels should be attached to the body of the container and not the lid. It should also include the patient's name, ID number, date, and time of collection. Under no circumstance should the label be detached even if the container is refrigerated or frozen. For requisitions, they must accompany the specimen delivered to the lab, and information must always match the specimen label. So what are the grounds for specimen rejection? These are the situations when specimens are deemed unacceptable. Number 1, when specimens have unlabeled containers. Number 2, when the labels and the requisition forms do not match. Number 3, when the specimens are contaminated with feces or toilet paper. Number 4, when the containers of the specimens have contaminated exteriors. Number 5, when the specimens have insufficient quantity. And lastly, when specimens have been improperly transported. but always take note to never discard a specimen before checking with a supervisor. For specimen handling, the integrity of the specimen should be maintained and tested within 2 hours. If the testing is delayed, specimens should be refrigerated or appropriately preserved. When preserving a specimen, the most common method is refrigeration at 2 to 8 degrees Celsius. And if urine is to be cultured, it should be refrigerated during transit and kept refrigerated until cultured for up to 24 hours. When preserving samples that will be transported to another laboratory, be sure to check with that laboratory concerning the appropriate preservatives. For changes in unpreserved urine, specimens must be returned to room temperature before testing with the reagent strip, because reagent strips work best at room temperature. These are the analytes that are increased in unpreserved urine: color, odor, pH, nitrite, and bacteria. On the other hand, these are the analytes that are decreased in unpreserved urine: clarity, glucose, ketones, bilirubin, urobilinogen, RBCs, WBCs, casts, and Trichomonas parasites. Next is for the types of specimens. The random specimen is the most commonly received, and this is for ease and convenience of the patient. It may be collected at any time, but the actual time of voiding should be recorded. It may show erroneous results resulting from dietary intake or physical activity before collection. It is useful for routine screening tests. And for the first morning specimen, this is the ideal screening specimen. It is essential for preventing false negative pregnancy tests, and it is important for evaluating orthostatic proteinuria. It is a concentrated specimen, assuring detection of chemicals and formed elements that may not be present in dilute urine. Many solutes exhibit diurnal variations such as catecholamines, 17-hydroxysteroids, and electrolytes. These substances that exhibit diurnal variations show lowest concentrations in the morning and highest in the afternoon. When these substances need to be measured, a 24-hour collection is required. If collected in 2 containers, it should be combined and thoroughly mixed before aliquoting. Patients must begin and end the collection period with an empty bladder, and if concentration of a particular substance remains constant, the specimen is collected over a shorter period. If only an aliquot is needed, the amount saved must be adequate for repeat or additional testing. For catheterized specimens, these are collected under sterile conditions, and the most commonly requested lab test for this type of collection is bacterial culture. To perform a catheterized specimen collection, a hollow tube is passed through the urethra and into the bladder. A midstream clean catch specimen is a safer and less traumatic method than a catheterized specimen, but it is also ideal for bacterial culture and routine urinalysis. It is more representative of the actual urine because it is less contaminated by epithelial cells and bacteria, especially in women, and a mild antiseptic towelettes are recommended for cleaning rather than strong bacterial agents like hexachlorophene or povidone iodine. They should not be used. Suprapubic aspiration is the external introduction of a needle through the abdomen and into the bladder. It provides a sample for bacterial culture that is completely free of extraneous contamination. This type of aspiration can be used for cytologic exams. For prostatic specimens, a 3-glass collection is performed. First, the area is cleansed prior to collection. And for the first tube or the first glass, the first urine passed is collected in a sterile container. And for the second, the midstream portion is collected in another sterile container. And after collecting that, the prostate is massaged. And once the prostate is massaged for the third glass, prostate fluid will be passed with the remaining urine into another sterile container. For all specimens, a quantitative culture should be performed, but for the first and third, they should be examined microscopically. And in prostatic infections, the third specimen will have a WBC per HPF, and a bacterial count of 10 times than the first specimen. The second specimen is usually used for control for bladder and kidney infection. If it is positive, results in the third specimen are deemed invalid. In addition to prostatic specimen collection, is a pre and post massage test. It is a clean catch midstream specimen, the second urine sample after prostate massage. A positive result is significant of bacteriuria in post-massage, which is 10 times than in the pre-massage. For pediatric specimens, a soft clear plastic bag with hypoallergenic skin adhesive is attached to the genital area. Always check the bags approximately every 15 minutes until the needed amount of sample has been collected. For drug specimen collection, a chain of custody is observed. This is a standardized form that must document and accompany every step of drug testing, from collector to courier to laboratory to medical review officer and to the employer. The collection proper may be witnessed or unwitnessed. If it is witnessed, a same gender collector will observe. The volume for drug specimens is recommended to be 30 to 45 ml, and the temperature should be taken within 4 minutes, and it should be 32.5 degrees Celsius to 37.7 degrees Celsius. If the temperature is outside the recommended range, this may indicate contamination. Next, we shall discuss renal function tests. First, for the glomerular filtration tests or the clearance tests. These measure the rate at which the kidneys are able to remove a filterable substance from the blood. The factors of a substance that ensure accurate measurement are as follows. The substance must neither be reabsorbed nor secreted with the tubules. It should be stable in urine for up to 24 hours. Its level of consistency in the plasma and its availability in the body. We should also consider the tests available to analyze such substance. Next is the urea clearance. This is the earliest glomerular filtration test. Approximately 40% of the filtered urea is absorbed. For inulin clearance, this is the original reference method for clearance tests. Inulin is a polymer of fructose. It is extremely stable, and it is not reabsorbed, nor is it secreted by the tubules. It is not a normal body constituent, and it must be infused by IV. Another type of clearance test is the creatinine clearance. Creatinine is a waste product of waste metabolism. Normally, it is found at a relatively constant level in the blood. It is not a reliable indicator in patients suffering from muscle wasting diseases, and it is also not reliable for patients involved in exercise or athletes supplementing with creatinine. It must be corrected for body surface area, and it is always corrected for children. The formula for creatinine clearance is as follows. Urine creatinine multiplied by urine volume over plasma creatinine multiplied by 1,440. Everything then is multiplied by 1.73 all over A being the actual body size. The actual body size may be calculated as log A is equivalent to 0.425 multiplied by log weight plus 0.725 multiplied by log height minus 2.144. Another test to assess glomerular filtration is the estimated glomerular filtration rate. The most common is the modification of diet in renal disease or MDRD, and presently recommended by the National Kidney Disease of Education Program is the MDRD IDMS or isotope dilution mass spectrophotometry. Next is cystatin C. It is for monitoring and screening of GFR. Cystatin C being a small protein produced at a constant rate by all nucleated cells. It is readily filtered by the glomerulus, and no cystatin C is secreted by the tubules. It is reabsorbed and broken down by the renal tubules, and serum concentration is directly related to GFR. Immunoassay procedures are available, and cystatin C is a test recommended for pediatric patients, persons with diabetes, elderly, and critically ill patients. Another test to assess for glomerular filtration is the beta-2 microglobulin. Beta-2 microglobulin usually dissociates from human leukocyte antigens at a constant rate, and it is rapidly removed from the plasma by glomerular filtration. It is not reliable in patients with a history of immunologic disorders or malignancy. Next is the radionucleotides. It is more labor-intensive and costly in determining glomerular filtration through plasma disappearance of the radioactive material. The next type of test to assess for renal function are the tubular reabsorption tests. The loss of tubular reabsorption capability is often the first function affected in renal disease. For the first tubular reabsorption tests are the concentration tests. These tests determine the ability of the tubules to reabsorb the essential salts and water that have been non-selectively filtered by the glomerulus. And for osmolality, for a more accurate evaluation of renal concentrating ability, this measures number of particles in a solution. Usually, patients are deprived of fluid overnight, and it is followed by urine sample collection. Greater than or equal to 800 milliosmol is considered normal, and the test can be discontinued. If the result is abnormal, fluid intake is restricted for another 2 hours, and then urine and serum samples are collected. Next are the usage of the freezing point osmometers. Freezing point depression is the first principle incorporated into clinical osmometers, and the sample is supercooled to 27 degrees Celsius, vibrated to produce crystallization of water in the solution. A thermistor is a temperature-sensitive probe that measures the increase in temperature. 1 mole of a non-ionizing substance per kilogram, which is water, lowers freezing point by 1.86 degrees Celsius. Vapor pressure osmometers measures the dew point, which is the temperature at which water vapor condenses to a liquid. Samples are placed in a small filter paper disc and into a sealed chamber with a thermocoupler. The sample evaporates and turns into vapor, and the chamber temperature is lowered and the water condenses. The heat of the condensation produced raises the temperature of the thermocoupler to the dew point temperature. Usually, vapor pressure osmometers are used primarily to analyze serum and sweat microsamples for disorders not related to renal function, such as cystic fibrosis. Technical factors that should be considered when testing for tubular reabsorption are as follows. First is a lipemic serum. Erroneous results with vapor pressure and freezing point osmometers. Second is lactic acid, which falsely elevated results in both methods. And lastly, volatile substances, elevated results in freezing point osmometers. Next test is the free water clearance. Water deprivation and a timed urine specimen is performed, used to determine the ability of the kidney to respond to the state of body hydration. When water clearance is a negative number, it can be a possible dehydration. When it is 0, it could be no renal concentration, and when it is a positive number, it could be excess water is excreted. Next is the p-aminohippuric acid test, or the PAH test. It is a test that is most commonly associated with tubular secretion and renal blood flow. It makes use of an exogenous substance that is removed from the blood in the peritubular capillaries. Plasma PAH is secreted by the proximal convoluted tubule, and the reference range is 600 to 700 ml per minute. The last tubular reabsorption test is the titratable acidity and urinary ammonia. In acid urine, hydrogen ion secretions by the tubules, and ammonia production and secretion by the cells of the distal convoluted tubules. Diurnal variation of urine acidity consisting of alkaline tides appears shortly after arising and postprandially between 2 p.m. and 8 p.m. The lowest pH is found at night, and in renal tubular acidosis, which is the inability to produce an acidic urine. Urine pH, titratable acidity, and urinary ammonia, these are measured to determine which function is defective. It is primed with an acid load of oral ammonium chloride, and fresh or toluene preserved urine specimens are collected at 2-hour intervals. Titrate the amount of free hydrogen and total acidity of the specimen. Calculate ammonium concentration by getting the difference between titratable acidity and the total acidity. And that concludes today's lecture. Thank you for listening.